Dietary phosphorus restriction is the mainstay treatment in the management of chronic kidney disease for both humans and veterinary patients alike. In chronic kidney disease, there is a reduction in the renal filtration of phosphorus, leading to retention and a rise in serum phosphorus. Hyperphosphatemia and the development of renal secondary hyperparathyroidism are detrimental sequelae, which leads to osteodystrophy, mineralization of soft tissue, and the progression of the renal disease. Numerous studies have shown that feeding a phosphorus-restricted diet reduces the risk of renal secondary hyperparathyroidism and slows the progression of chronic kidney disease. It is not the case that the lower the phosphorus level, the better for patients with CKD. Phosphorus is an essential nutrient that plays an important biological role, particularly with maintaining calcium balance. Studies have shown that approximately 75% of cats in early non-azotemic chronic kidney disease and about a third of cats with azotemic CKD can develop hypercalcemia that is associated with feeding a diet that is low in phosphorus. In response, switching these cats to a more moderately restricted phosphorus diet has been shown to reduce their blood calcium concentrations. So the level of dietary phosphorus restriction does need to be tailored to each patient, their clinical signs, and their stage of renal disease. In patients with chronic kidney disease, we want to ensure that they are eating a diet that meets their protein requirements and reduces the loss of muscle, but to also limit any excess. Excess protein is not stored in the body and instead is catabolized for energy. In addition, excess unabsorbed proteins in the gastrointestinal tract are degraded by bacteria, and the byproducts are absorbed in the colon. These nitrogenous waste products from protein catabolism and bacterial degradation can build up as renal function declines. Waste products such as indoxyl sulfate and p-cresyl sulfate have been implicated in causing the signs of uremia in human patients with CKD. The risk of waste production accumulating and uremia is highest in the later stages of CKD. So it's thought that protein restriction is more important during these later stages of IRIS stage 3 and 4. The exception to this is if the patient is proteinuric. An elevation in urinary protein is often a significant independent risk factor for the survival of dogs and cats in CKD. And so protein restriction is indicated in these cases, even if the patient is only in the early stages of renal disease. In general, a higher protein diet will have a higher phosphorus content. However, that's not always the case, and not all phosphorus is equally bioavailable. Organic phosphorus from animal proteins and inorganic phosphorus from supplements are more easily digested and absorbed compared to phosphorus derived from plant ingredients. We know a key driver of diet selection for cats is protein, whereas for dogs it appear to be more driven by dietary fat. So a diet with lower protein content can be less palatable compared to a high protein diet, particularly for cats. However, companies that make renal diets, for instance, work really hard to ensure that they are palatable and eaten well despite their protein restriction. We can leverage other factors such as odor, flavors, and textures to ensure a good appeal for them. The overarching goals for dietary management of CKD should be aimed at stabilizing hyperphosphatemia, maintaining blood calcium in a normal range, and ensuring adequate caloric and protein intake. However, we now know that in some cats in early renal disease have a risk of developing hypercalcemia when they're placed on a traditional low phosphorus renal diet. And so the current recommendation is that cats in IRIS stage 1 and early IRIS stage 2 should be placed on an early renal diet, which is one that is more moderate in its phosphorus restriction. Then, in the later stage, once creatinine is elevated, a standard renal diet can be recommended. often a patient with CKD is monitored should be determined on a case-by-case basis. The progression of the disease and the development of comorbidities will ultimately influence this decision. In general, however, the ISFM consensus guidelines suggest that rechecks after the initial diagnosis should be done once every 1 to 4 weeks. Once the patient is stable, then they can be reevaluated every 4 to 6 months at least. As part of the evaluation, a full history, clinical examination, including body weight changes, muscle condition score, hydration status, and blood pressure should also be assessed. Also, a urinalysis, hematology, biochemistry, including ionized calcium if possible, should be performed. In addition, in some cases, they may also require diagnostic imaging.